So thanks for that nice introduction, and thanks so much for the opportunity to present here. It's so great to see friends that we haven't seen in person since pre-COVID times. And what I would like to do is take you through something that you may not see every day or every few days either, but we have started to see a lot of, and that is cardiovascular effects or adverse events related to immune checkpoint inhibitors, and especially myocarditis. These are my disclosures, none of which are related to the talk today. So as we think about cardio-oncology over the years, in the late 1960s, 1970s, this all started with anthracyclines and related cardiomyopathy and heart failure. And then along came trastuzumab. And so cardio-oncology was often equated with heart failure. And now if we look in 2024, this is built up to so many different agents. Heart failure still forms a major part of what we see, but we see a lot of other things related to the cancer therapies, including hypertension, cardiometabolic conditions, vascular toxicities, increased coronary disease, arrhythmias, and of course, myocarditis. And this is going to keep increasing, not just because the drugs that come out for cancer therapies, but also the population. There's increased number of survivors because of the success of cancer therapies. And so we may see long-term effects in these patients too. So over the next 45 minutes, we will talk about what the usual clinical presentation of patients with immune checkpoint inhibitor-related myocarditis is, select some of the diagnostic and therapeutic strategies to diagnose this condition, and then how do you treat these patients, and then of course recognize that there may be other potential longer-term effects which we're still learning about. And if we look at the timeline of immunotherapy for patients with cancer, this started a while ago where it was sort of the non-specific rev up the immune system and see what happens to the cancer, development of some vaccines, both for prevention and treatment of various cancers. And then the exciting discoveries of these proteins or molecules called checkpoints. And of course, we'll talk some more about them, but this all started in the 1990s. And then in 2011, we had the first approval of the immune checkpoint inhibitor, the CTLA-4 inhibitor, for the treatment of metastatic melanoma. And since then, immune therapy has really come a long way. There have been other immune checkpoint inhibitors approved along the way. And I think every year or every month, actually, if you look back and you know what there was, you look back and, oops, I didn't know about this one that's on the market too. And the first discovery was really exciting for something like metastatic melanoma. With the use of immunotherapy, the survival went up to 50% at 5 years. And that was really the promise that this has brought along. And we'll talk a little more, but very aptly, the two scientists, Dr. James Allison, who's now at MD Anderson, and Dr. Honjo from Japan, were awarded the Nobel Prize in Medicine in 2018 for their discovery of two different checkpoints that then finally led to these therapies being developed. So what are immune checkpoints? Immune checkpoints are regulatory molecules on T cells and antigen-presenting cells that attenuate T cell activation, prevent unchecked immune system activation, and guard the body against autoimmunity. And these inactivated T cells, therefore, are not even able to kill the tumor cells. So if one is able to block these immune checkpoints, so basically you block something that is deactivating the immune system, it sets force of the natural immune system against the tumor. So you use the body's own T cells that are revved up now to kill tumor cells. That's really putting it simplistically, but that's the way I try to understand it. And there are different immune checkpoints. One of these is the cytotoxic lymphocyte antigen 4 or CTLA-4 checkpoint, which is present on T cells. And when this binds with the B7 proteins on the antigen-presenting cells, basically T cell activation is prevented. And so these T cells are not able to kill tumor cells. Using antibodies, the first one that was developed was this anti-CTLA-4 antibody. When it binds to CTLA-4, it allows the T cell to be activated by the antigen-presenting cell, and the T cells are then able to kill the tumor cells. The other the other utilized immune checkpoint inhibitors are those against the PD-1 or the program cell death 1 protein, as well as its ligand PD-L1. And so usually PD-1 on the T cell binds to PD-L1 on the tumor cell and prevents the T cell from killing the tumor cells. But by using antibodies against either PD-1 or PD-L1, these activated tumor cells are able to kill the tumor cells. The T cells are able to kill the tumor cells. And so in a nutshell, that's how immune checkpoint inhibitors work. And as I mentioned, starting off in 2011 with the approval of ipilimumab, the first CTLA-4 inhibitor, to now where we have probably 11, or there may be even more that I may have missed, which are PD-1 inhibitors, PD-L1 inhibitors, and then recently something that was targeting LAG-3. And starting off with metastatic melanoma, and over the years, these immune checkpoint inhibitors have been approved for numerous cancers, and earlier, starting only with metastatic melanoma, they're now being used earlier and earlier in the disease course of cancer. They're also being used in combination for certain cancers, and it's expected that over the next several years, about 40 to 50% of all cancer patients will be eligible for immune checkpoint inhibitors, which is pretty remarkable. Unfortunately, by unleashing the body's own immune system, it also sort of creates an autoimmune state where the T cells that are activated can attack almost any organ and create issues. So commonly, it's skin lesions, which are often treated easily. Colitis is fairly common. Thyroiditis is fairly common. But then there's others that can really lead to higher mortality, and of course, myocarditis being one of them. Again, this slide goes over of the reported immune-related adverse events, or IRAEs, as they're usually called. Colitis is quite frequent. The mortality associated with it is, though, low. Myocarditis, fortunately, is uncommon, but the mortality, especially initially reported, was pretty high, somewhere between 40 and 50% of all cases seen. So again, why do we care about immune checkpoint inhibitor myocarditis if it's really not that frequent? Is the high fatality rates unless recognized early and treated early. And as we've talked about, the fact that 40 to 50% of all cancer patients may be eligible for these therapies. So we're going to see a huge denominator in which this condition will be seen more and more. So just starting off with the case, and I'll try to keep this case in view as we go through the various aspects of immune checkpoint inhibitor myocarditis. So this is a very standard presentation. So 77-year-old male with a history of metastatic melanoma, and 3 weeks before presentation had the first infusions of dual checkpoint, so both a CTLA-4 and a PD-1 inhibitor, and actually came for his second infusion when he complained of severe fatigue, lightheadedness, some changes in the voice, and muscle pain in the legs. And on exam, although his blood pressure was okay, his heart rate was only 39. He was initially sitting fine. And just briefly, positive pertinent findings were a right eye ptosis and some weakness of the hip muscles and muscle tenderness diffusely. His EKG in the ER showed high-grade AV block, and his labs were abnormal, including an increased or worsened renal function. Transaminases were elevated, and he had very significant elevations of CK, CKMB, troponin T, which is a high sensitivity. And we also send out troponin I. We don't do both T and I at our institution. And this was the regular troponin I of 16. NT-proBNP was elevated. And his echo, though, looked pretty normal, just with normal EF and normal wall motion. And we'll keep coming back to the case as we go along. So as I mentioned, ICI myocarditis is pretty infrequent. And initially in the clinical trials was probably reported at the much lower end because it was not being recognized. People were not actually expecting it. So an initial incidence of about 0.36%. But as we've gotten better at recognizing the condition, as we've started to use dual checkpoints, the incidence may go up to about 1.5% of all patients receiving immune checkpoint inhibitors. And really the only risk factor that we've definitively identified is this dual checkpoint inhibitor use. And often myocarditis occurs early after patients start immune checkpoints, either after the first or the second cycle of immunotherapy. And from various studies, including one from our group, the median onset was about 28 to 34 days, and 80% of the cases actually occurred within the first 3 months of starting immune checkpoint therapy. There have been late reports, even up to about 300 to 400 days, but if our suspicion goes down a lot if patients pass that initial 3 to 4 months after checkpoints are started. About 30 to 40% of patients actually present with myositis-like picture or a myasthenia-like picture. And the prognosis is much worse in these patients with overlap. And often the prognosis may be driven by something like respiratory failure because of diaphragmatic involvement. So it's not the myocarditis that may kill these patients, but something that occurs with it, which is equally important. And as I mentioned, the initial fatality rates were 30 to 50%, but in the more recent literature with more early recognition, more aggressive treatment, we're seeing relatively lower rates. So what is the pathophysiology? As I mentioned, immune checkpoint inhibitors basically activate the T-cell mediated tumor killing, but these T cells also can attack almost any organ in the body, and the heart is one of them. And usually this is a lymphocytic myocarditis with T cell and macrophage infiltration. And some of the autopsy studies and more recent studies, including from our group, have shown there's clonal activation of these autoreactive T cells, and similar clones are present in the heart, the muscle, and maybe even in the tumor. So there may be some cross-reactivity of antigens across these different organs. And then some have postulated maybe this is just a potential bystander mechanism where the heart may already have inflammation or damage from something else. The PD-L1 on myocytes and endothelial cells is exposed. The antibodies may be driven against those, or it's just cytokines being released and attacking, causing myocardial damage. However, that lower incidence tells us it may not just be this bystander mechanism, but there may be something more specific, such as the cross-reactivity of tumor antigens. But we're continuing to learn about the pathophysiology. As I mentioned, the clinical presentation often is really non-specific symptoms, such as dyspnea and fatigue. And in patients with cancer, these are very common complaints. And so unless one really looks at what patients are on and what exactly they're complaining of, it is something that can be easily missed. Sometimes they present with cardiac symptoms, of course, chest pain, syncope, palpitations. A few present with overt heart failure. It's not one of the common presentations. Arrhythmias are much more common, including atrial fibrillation, but in the more fulminant myocarditis, we see ventricular arrhythmias as well as heart block, just like our patient presented with high-grade AV block, and that is really not unusual, maybe even in up to 17 to 20% of cases. A few patients will present with severely impaired LV function or biventricular dysfunction and maybe in cardiogenic shock. And then, as I mentioned, this overlap syndrome of myositis or myasthenia, again, something to really ask for because it affects the management and may drive their prognosis even more than the cardiac condition. And some of these patients have developed hypercapnic respiratory failure, need to be on ventilation, and some of them do not come off the ventilator. So again, if not recognized early, that can be the cause of death. Going back to our patient presented with dyspnea and fatigue. He didn't actually come in for a separate visit, but came in for his infusion and then complained of these symptoms. Had advanced AV block, muscle weakness, pain, eyelid drooping, dysphagia, and later developed dysphonia. And not initially, but later in the course, did require some ventilatory support. So how do we diagnose this? And it's taken a while to try to come to a consensus of what can we call a definite diagnosis of immune checkpoint-related myocarditis. These patients are often sick and are not often able to have all the testing needed. But if a biopsy, which is thought to be the gold standard, is done, and you see both multifocal inflammatory cell infiltrate, which, as I mentioned, was usually lymphocytes and macrophages, and overt cardiomyocyte loss or necrosis, that is, and then putting it into the temporal concept of when the patient was started on immune checkpoints, that can that's a definitive diagnosis of ICI myocarditis. However, often we don't have the endomyocardial biopsy to begin with, or many institutions don't do these routinely. So this was from the International Cardio-Oncology Society and the ESC to try to come up with a standard definition of almost universally, these patients have troponin elevation. So if that is associated with one of the major criteria, which is the CMR with the definitive modified Lake Louise criteria, then that's counted as a definite diagnosis of myocarditis. But patients may not always get a CMR, or they may not have the classical signs on the CMR. And so troponin elevation with some of these two minor criteria, which could be clinical criteria, electrical instability, decline in LVEF, or the overlap symptoms with myositis or myasthenia, and a suggestive CMR, you may have one of the two modified Lake Louise criteria. And it's always important to not overlook something else that may be causing those similar symptoms of chest pain or troponin elevation. They can still have acute coronary syndrome or a type 2 MI or have other causes of myocarditis. And there again is tried to be some consensus on defining the severity of checkpoint myocarditis as well as phases of recovery. And so what do we use for diagnostic testing? This is similar to what one would use in other cases of myocarditis too, but as I mentioned, usually labs with troponin levels, and we'll talk about whether it should be I or T, but sometimes we're just, these are based on what the institution offers. And so we're lucky, we do troponin T, but we are able to send out troponin I. And so we try to use both because they both have their benefits and downsides. Of course, we do total CK, CKMB, and then the natriuretic peptides, whichever one is available. Imaging, EKG, and telemetry monitoring, of course, echocardiogram, CMR, and then procedures-wise, if one does do an endomyocardial biopsy for complete confirmation, but then remembering that we do need to exclude coronary disease as contributing. So going over each of these individual tests, EKG and ICI myocarditis, there's a few international registries and one which we're part of too. So EKG changes are pretty frequent with myocarditis. The issue really is that a lot of these changes are not specific for myocarditis and can be seen with various other conditions. But as would be expected, the heart rate can be increased. There may be new Q waves, QRS prolongation, classic bundle branch blocks, PVCs or other arrhythmias, The voltage decreases, again, felt to be related to the myocardial edema with the acute inflammation. And then QTc prolongation, which is pretty much standard for most of our cancer patients with what they're on. And as I was mentioning before, the ventricular arrhythmia is seen again in about 15%, and heart block of some degree or severe sinus bradycardia may be seen in about 17% of cases, at least from these registries. And of course, these presentations are then associated with worse 30-day mortality or longer-term mortality. And in our patient, again, we had seen heart block, and even after he was treated, we put in a temporary pacemaker, and with treatment he recovered. So we usually put in the temporary with an external fixation lead that allows us to keep in the pacemaker for quite a while, because the majority of our patients actually recover the conduction issues and are able to not need a permanent pacemaker. So again, something to think of, and we don't need to jump ahead and put in a permanent pacemaker right off the bat. And then cardiac biomarkers, the initial recommendations are to use troponin I, thought to be more specific just for the heart. And that makes sense. But again, as I mentioned, some of it, the limitation is what we have available. But there was this recent study from Joe Ely's group in France, where they looked at patients, of 60 patients who had both troponin T and I available. Of course, this was not a prospective protocol. So they may not all have been done exactly at the same times. But what they found was, if you look at troponin T, which is in the yellow, the troponin I, which is the blue, and then the dark gray is CKs. And from top to bottom is the time after presentation, dividing it up by, initially 0 to 3 days, 4 to 7 days. But early on, almost all patients are positive for troponin T elevation, whereas there is a percentage of patients that don't have troponin I elevated right off the bat. And what we see is troponin T is elevated early, it stays high, and even if it comes down, it may stay elevated for a longer period of time, whereas troponin I, usually it may be, or in majority of cases, it is elevated at presentation, but some of the patients who are negative at presentation do have an elevation in the next day or two, but then it comes down much faster and stays down. And this may be, it makes sense that if patients just have cardiac involvement, troponin I is the marker, but 30 to 40% or even more of these patients have skeletal muscle or myasthenia-like syndrome, and the troponin T probably remains elevated related to those. So what this group found was that it was actually the troponin T that was a better prognostic marker of both cardiac and muscle outcomes compared to troponin I. And NT-proBNP and BNP are useful if they're negative. We can usually then say that this patient probably doesn't have an elevation in filling pressures, but if they're positive, especially in cancer patients, they often are not that helpful. And so, yes, we look at them, but they do not drive day-to-day management in these patients. Of course, if it's like 5,000, 10,000 NT-proBNP, very likely this patient has some increased wall stress and elevated pressures, but we do see a number of patients in the cancer world where patients come in, NT-proBNP is about 800, 900,000, and you do their echo and their filling pressures look completely normal. Clinically, they don't appear to have heart failure. And it's thought that maybe this is a inflammatory marker too. So I went from the VA where we used to look at BNPs, and they were fairly good, except of course there were circumstances, it was not always specific, to a world where there's so many elevated NT-proBNPs, I don't know how to use them in my practice unless I know my patient has heart failure and over time or as an outpatient, I can follow them. And this is that same study again, where they showed that troponin T was predictive of poor cardiovascular and muscular outcomes. Of course, the cutoff they took here for the high sensitivity troponin T was 32 times elevation of normal, which is then a very, wide extreme. And again, as we mentioned, at the time of the major adverse cardiac event after presentation, which included either heart failure, ventricular arrhythmias, AV block, respiratory muscle failure, etc., 23 of those 23 patients had troponin T elevation, whereas at the time of the MACE event, there were still 2 out of 19 patients who did not have an elevation in their troponin I. And again, CK may be elevated initially, but tends to come down the first and then remain down. So going back to our case, this is the troponin T versus troponin I story. And this was his troponin, again, troponin I, this was regular troponin I, and it was high sensitivity troponin T. But in the red dotted line, or orange, I think, it was troponin I was elevated early on in this patient, but came down very rapidly after treatment and stayed down. Whereas the troponin T, he came in high, decreased a little, but then it went up and stayed up for quite a while. And I think this was related to his other muscle issues rather than cardiac. Then what about echocardiography? So yes, of course, we get it on everybody that presents like this, but the majority of patients of the EF actually remains normal. So 50 to 60% of cases, EF looks totally fine. And normal EF by itself does not predict a good outcome. Yes, really depressed EF of 20% at presentation is likely to be associated with a worse prognosis, but the fact that we're seeing the patient, their EF is normal, should not be something to say we have time to treat this patient. And one of the international registries showed that strain was an independent predictor of major adverse cardiac events. And I think it makes sense. You're detecting something at a more sensitive level. But even with normal EF, lower strain predicted worse outcome. And then to go back to cardiac MR, and very useful. Not every patient can have an endomyocardial biopsy, but patients can be unstable and may not be able to get a CMR too. But again, using the same modified Lake-Louise criteria that are used in general for myocarditis, you want a finding in both T2 and T1 imaging that are positive to make it definitive myocarditis. And what was found in one of the registries where if one looked at these 2 different criteria, the criteria for edema was present in only 43% of patients with what was thought to be definite ICI myocarditis, whereas the findings for non-ischemic injury were present in the majority. But compared to non-ICI myocarditis, where the modified Lake-Louise criteria are thought to be about 80 to 90% sensitive, it was found that in this registry, at least, they were only about 53% sensitive. And late gadolinium enhancement, again, in non-ICI myocarditis is often present in up to 80% of cases, but in the biopsy-proven cases, it was present only in about 38%. So again, a decreased sensitivity of CMR in ICI myocarditis, and this may be related to the timing. If one performs an MRI early, before 4 days of presentation, the sensitivity or the LGE was only seen in about 22%, whereas it increased if the MRI was performed later. And again, you want a diagnosis early on, pretty soon after the patient presents, rather than waiting for 4 days. And of course, by the time patients may get MRIs, they may have already received steroids, and that may have something to do with the findings on MRI. Of course, not every place does great MRIs like you guys probably do. So I think the sensitivity in the real world may be even lower than what was reported here. And some of the findings on CMR have been shown to be prognostic, especially findings on abnormal T1 times were predictive in this particular registry. What about PET? People have said there's inflammation, and if MRI is not great, maybe PET, FDG PET, which is always available even in cancer hospitals, could be a good test. So there's another group, and we tried it at our place too, but it's really, first of all, logistically very infeasible to do FDG PET for these acute cases. They require a diet prep of from anywhere from 24 to 72 hours of low carbohydrate, high fat diet, ketogenic diet. And, when patients are either getting plasmapheresis or getting IV infusions, there's no way to do that. And also the delay in trying to get the patient to the PET lab. So in our case, we abandoned it after trying it on about 10 patients. We did not felt in the acute setting that this was useful. But the good news is there is work being done with specific tracers. So the CD8 cells are really the predominant infiltrate in the myocardium that we see with this lymphocytic myocarditis. And there are novel PET tracers that may target CD8 cells specifically and may hold promise. And so we are also starting work at our place looking at some of these novel markers to see if they can help make a diagnosis that may be non-invasive and rapidly available. And then what does the endomyocardial biopsy show? It is the gold standard for diagnosis, but again, the criteria are similar to non-ICI myocarditis. So you want both inflammation as well as cell death to make the definitive diagnosis of myocarditis. The cells that are seen are mainly the CD8 cells, which are the killer T cells, but you also see CD4 cells and then CD68, which are the macrophages. And there is increased staining of PD-L1. We talked about PD-L1 antibodies being one of the immune checkpoint inhibitor antibodies, but PD-L1 is expressed on cells even other than tumor cells, and it's expressed in the myocardium, usually at a pretty low level, and can be expressed on the endothelium too. But the thought is maybe with injury, PD-L1 is expressed much more and maybe offers a direct site for PD-L1 antibodies to bind. But in all the cases, and I'll come to our series that have been published, PD-L1 staining is pretty high in those with definitive myocarditis. And the findings on biopsy are very similar to what is seen with acute post-transplant cellular rejection. As far as antibody involvement, there has been work. There have been a few cases reported with pericapillary C4d staining, which may suggest that antibodies are involved, but this is not universal and actually seen only in few cases. The other issue is that myocarditis is often patchy. And so, of course, we usually take about 4 to 6 samples, and I'm sure you all do that too, but you can still miss the diagnosis even if you don't get the sample from the right site. And again, although this is the gold standard, every center has its own comfort level of doing biopsies based on the expertise. Transplant centers, of course, have a lot of expertise. We do a lot of biopsies at our place too, and are thankful for that. But in other places, I think there's always, it is the non-invasive test that one has to rely on to make the diagnosis. And then our thought was, is there a way to use the endomyocardial biopsy findings to actually classify the severity of myocarditis and possibly to guide guide therapy as well as to guide rechallenge of ICIs in some patients who may not have any other therapies available for cancer treatment. So this was a smaller series from MD Anderson, 28 patients that underwent biopsy for suspected immune checkpoint inhibitor myocarditis. 18 were positive with some findings. And with Dr. Bouya's help from UT, we developed a grading system where grade 1A and grade 1B patients just had inflammatory infiltrates, but no necrosis seen on the samples that were provided, and divided A and B based on the number of inflammatory cells per high power field. And then grade 2 was really the ones that had both the inflammatory infiltrate and the necrosis. And the grade 2 patients also had that high PD-L1 staining. We saw some PD-L1 staining with grade 1B, but not in the lower grade 1A patients. And the troponin levels, yes, did correlate, were highest, much higher in the grade 2 patients as compared to grade 1 and B, or 1A and 1B. But we had 2 deaths in both grade 2 as well as the grade 1A and 1B. And in fact, one of the cardiac deaths was in the grade 1 patients. So again, not a one-to-one correlation of being totally predictive, but grade 2 patients are usually the ones that present with much more severe illness. And we did biopsy our patient, going back to him, and we saw the grade 2 with definite inflammatory infiltrate and necrosis and heavy PD-L1 staining. So again, trying to bring these tests back together. Each one has its own drawbacks, and really it's putting everything together and the patient presentation. In our patient, I think we almost didn't need, after his clinical presentation, EKG and troponins, we almost didn't need any other testing to confirm that it was a classic presentation, but not every patient is like that. There's some patients that present with asymptomatic troponin elevation. There are some patients that present with very nonspecific fatigue and nothing else. And so in those cases, of course, clinical exam, troponin in everyone, EKG, looking for arrhythmias, and then association of non-cardiac IRAEs, especially the myositis and myasthenia, points us towards ICI myocarditis. Always important to rule out the coexisting coronary disease or ACS. But even if after finding, say, a 70 or 80% lesion, to make sure that it all fits together as an ACS presentation, because people have been burnt where you think it's ACS, you stent the LAD, and then 2 days later, the patient actually dies because of the myocarditis. So it's really important to match that clinical presentation with findings that are seen. And then we talked about limitations of CMR, endomyocardial biopsy. And so putting it all together again, what do we do at MD Anderson? And this is what a lot of other folks do too. Before ICIs are started, there's been now a push to really try to get a baseline EKG and a baseline troponin CK on these patients, just so we have something to compare to if they come back with some nonspecific symptoms and you have a mildly elevated troponin. As we can look back and see, is it really different from what it was? And we usually follow the patients clinically. We don't do any other troponin follow-up as routine surveillance or EKGs as routine surveillance because the yield is not that high. But in somebody presenting with suggestive symptoms, as we've discussed, we do the usual biomarkers, clinical exam, and if we suspect myasthenia, the neuro-oncologists do send off the ACH antibodies. We may perform muscle biopsies, EMGs. It's important to always get a TSH and a cortisol because these patients can present just with dyspnea, fatigue, and we see a lot. TSH being low or elevated and hypothyroidism is really very, very common in patients on checkpoint inhibitors. And some of them can even have CK elevations and a myopathy related to the hypothyroidism. So it's important not to miss that. Cortisol, again, related to ICI use. And then if we think there's a likely alternative diagnosis, of course, you go for that, ACS, type 2 MI, et cetera. But if not, then we usually like to perform an endomyocardial biopsy and cath the patient at the same time, rule out coronary disease. But if a patient is not able to do that, consider CMR. And if we think the diagnosis is likely, of course, we don't wait before treating. We start off with steroids while we complete the diagnosis. And some of the things that may initially tell us that this patient may need to be watched closer, have more aggressive treatment are, as we mentioned, dual ICIs not only increase the incidence of myocarditis, but they also cause earlier presentation and more severe presentation. So that is something useful to keep in mind. Patients presenting early after starting checkpoints usually have a more severe course of their myocarditis. Of course, if they present with hemodynamic or respiratory instability, that right away tells you. And then the patients with overlap myositis or myasthenia don't do as well. And as I mentioned, the cause of death may be related to more the muscle weakness, the diaphragmatic muscle weakness. And they are on the vent or they get infected, and that may be what causes the death. Thymic malignancies, the use of ICIs is not really advocated in these ones, but when used, there's been a very high incidence of checkpoint myocarditis and myositis with thymic malignancies. And a delay in starting treatment is associated with a worse prognosis. And then, as expected, worse EKG abnormalities, worse heart block, presenting with incessant VT, et cetera, are all related to a poorer prognosis. And how do we treat them? So the first thing is to hold the immune checkpoint inhibitor while we figure it out. Then start high-dose steroids. Initially, people started off using lower doses of 1 to 2 mg per kg, but based on retrospective studies, which I'll share with one of them with you, it is really recommended using high-dose steroids. So usually we start off with 1 gram of methylprednisolone for the first 3 to 5 days. And then if the patients don't respond, or once the dose of steroids is reduced, if they have a recurrence of symptoms or biomarker increases, then an additional immunomodulator is recommended. There is some talk now of adding on a second immunomodulator early, but those are in trials. And then, of course, the supportive cardiovascular therapy and mechanical ventilation as needed. So if we think about the treatment, it's pretty much the kitchen sink of all immunosuppression. And, steroids, definitive for now. That view may also change, but thinking it is a T-cell mediated process using ATG or after steroids, they may need mycophenolate or tacro if they're not responding as well. But we have used antibody-mediated therapy also. And part of it is, especially in the cases with myasthenia, where it's thought that there is an antibody-mediated process ongoing, or even with the peripheral skeletal muscle involvement, we do use plasmapheresis at a high rate and can use IVIG or rituximab. And because this process is thought to be highly driven through cytokines, there is data for using infliximab or ruxolitinib, and I'll share some of that data with you. Again, remembering that infliximab may not be used in patients with either low EF or frank heart failure because of its known adverse event profile. And then there's biologic agents, especially abatacept, which is an CTLA-4 fusion protein, which directly then counteracts the effects of CTLA-4 inhibitors and supportive therapy. And as I mentioned, the steroids usually using high doses, but we like to taper them over 4 to 6 weeks. So relatively rapid taper after that if patients are responding. If they're not responding, add a second immunomodulator because of the known adverse events that are seen with long-term steroids. And in our patient, we treated him initially with high-dose steroids because he seemed to have a component of myasthenia, got plasmapheresis as well as IVIG, had a temp pacemaker with external fixation leads, which I think we kept in for 2 weeks, and then didn't go home with a pacemaker, but did go home with the new right bundle and a left anterior fascicular block, which were new as compared to before, and did require temporary BiPAP support while in the hospital. After he left the hospital, the steroids were tapered, but then he had a recurrence of myasthenia symptoms, and he got intermittent IVIG over the next year. And exactly a year later, unfortunately, he was admitted with metastatic melanoma symptoms. There was no other therapy, and he was then discharged on hospice. So again, as I mentioned, high-dose steroids, where does this data come from? This is really based on this retrospective registry study where they looked at the group that got high-dose steroids, intermediate dose, and low-dose steroids, and high dose was considered 501 to 1,000 milligram per day, and the patients with high-dose steroids did better. So that's where our data is currently. As far as using other molecules, as I mentioned, there's this biologic agent abatacept, which is used for rheumatoid arthritis in juvenile RA, which is a CTLA-4 fusion protein. So it basically binds the source and acts exactly contradictory to the CTLA-4 antibodies and is thought to be very specific for this condition and for the downstream effects. And there have been some more recent data using this in prospective studies, but not really randomized trials. We don't have the data from randomized trials yet. There's also been, from Joe Ely's group, again in France, data on reloxatinib, which I mentioned is a cytokine blocker. And because of the role of cytokines in this condition, they started this agent early, along with abatacept upfront. And it's thought abatacept may take a little bit longer to act, so they felt adding on reloxatinib may help upfront while the abatacept kicks in. And their results were almost too good to be true. What was initially mortality related to the cardio and myotoxicity of 60%, with this regimen, they reported as 3%. And overall mortality, again, from 70% down to about 30%. But I think we have to take this with a grain of salt. Mortality across the board has gotten lower with this condition because we know how to treat them better and recognize it earlier. But there are some ongoing trials. The important thing in this patient population is it's not just treating the myocarditis or the myositis, it's also the cancer at issue. Because if we treat the patient, their heart issues go away, but the cancer, progresses rapidly, that is overall, that's not really helpful. So there is this concern that whether using agents like abatacept or I can't pronounce all the cancer names, but reloxatinib can actually worsen the cancer status. And I think we have to look at that. Everybody says, no, it doesn't. It's early on, but these are 100-day studies, 6-month studies. And how do you take that same group of patients? How do you know what would have happened if you hadn't used these agents? So I think we need those randomized trials. And there is a risk of infection. In fact, if you look at the package insert for abatacept, it says, do not use with reloxatinib or other immunosuppressive agents. So there is a real risk of infection, which we have to be cognizant of. There is a multi-center trial called Atrium, which we are also participating in, where in addition to the upfront steroids, the patients are either randomized to receive abatacept or placebo. And this is looking at the primary endpoint of composite of major adverse cardiovascular events. The dose used here is that used for rheumatoid arthritis, and they do not allow patients who already present with one of these MACE events. So our patient who presented with high-grade AB block would not qualify for the trial because it was a primary outcome, part of the primary outcome. But it's a randomized trial, which is huge, about 390 patients, and hopefully it'll give us a better idea of whether adding on abatacept at the beginning, in addition to steroids, may be more helpful and improve outcomes. Again, we have to keep that cancer endpoint in mind and look at that carefully. Can we re-challenge patients with ICIs after they've had myocarditis? And of course, our first knee-jerk reaction is no. Why would you? But remember, some of these patients, or many of these patients, have no other alternative therapies, and ICI was the last treatment they were being tried on. So if somebody presented with what our patient presented with a severe course, I don't think we can really re-challenge them with ICIs. But there are some reports, including from our place, where ICIs were tried when the biopsy showed that really mild inflammatory infiltrate. We don't know what that means. And patients did okay, but these are really a handful of patients. One would have to monitor them really closely. If they were on dual therapy, maybe only one ICI, et cetera. But the jury's out on the subject, and it would have to be very close conversation with their oncologist and the patients themselves. I will skip this in the interest of time, but really there's no data on routine troponin surveillance. Some people advocate it and do it with every cycle of ICI. We feel like in this case, this was one from Stanford, they had about 190 patients, 24 patients had troponin elevations, of which 3 had myocarditis, but 2 of them were symptomatic. So it was a sensitivity of, or a positive predictive value of only 12%. So actually, Nick Palaskis at our place has just started a randomized trial looking at whether a surveillance strategy with troponins versus standard of care will actually improve cardiovascular outcomes, and also look at whether surveillance makes us hold ICIs more and may actually worsen cancer outcomes. So exciting, stay tuned. I will skip over this, but just to remember, pericarditis and pericardial effusions are thought to be increased in patients with on checkpoints, but we found a very low incidence of requiring TAPs. And generally, if they don't have associated myocarditis, we treat them as regular pericarditis, may even use low-dose steroids, but we don't stop the immune checkpoint inhibitor. There's also reports of increased vasculitis and increased thromboembolic disease, but again, these are retrospective reports. We treat them the way we would in any other patient. There is a concern for acceleration of atherosclerosis with immune checkpoints over the long term, because we're going to have an increasing number of survivors with these therapies. And as we all know, atherosclerosis is an inflammation-driven process. And so there is a theoretical risk that by increasing that process, we may accelerate or cause even precipitation of acute coronary syndrome. There have been some animal studies that suggest this may be true. There's infiltration of increased CD8 cells into the plaque in the aorta, et cetera. The plaque volume doesn't change, but the nature of the plaque with an increased necrotic core becomes evident. So while some retrospective studies have also suggested an increase in major adverse cardiac events post-ICI compared to before or compared to a control group, I think the jury is still out, and we need to learn a lot more about this. But it does bring home the point that if we see a patient with cancer, remember, risk factor modification is still important. If they need statins, we've got to do it then and not wait for the cancer to be cured, which is often the knee-jerk reaction. So we are really aggressive in treating risk factors. These patients have a high risk of cardiovascular events and mortality. So we need to do everything we can optimize to, one, get them through their cancer therapy, and second, to increase their longevity after cancer therapy. So finally, to conclude, immunotherapy with ICIs has really revolutionized the treatment of patients with cancer, and the number and use of ICIs continues to increase for an increasing spectrum of cancers and at earlier stages of cancer. And as I mentioned, over 40% of all patients may actually be eligible for these therapies. Even though the incidence of myocarditis is low, unless it's recognized early and treated, it can have a high fatality rate, and especially recognize the overlap with myositis and myasthenia, because it may contribute to their worse outcomes. Today, high-dose steroids are still first-line therapy, and adding on a second immunomodulator only if they don't respond. But we're looking at these strategies and whether adding on a second immunomodulator early may be important. And then stay tuned for the effects on atherosclerosis. So I'm sorry I think I'm still before 1, but thank you.